Thank you again for doing this interview. I know that you're a very busy person these days.
It's a pleasure to be with you. Happy to do it.
I think I speak for the vast majority of our readers when I say that we appreciate your candor and reassuring presence during the ongoing COVID-19 pandemic. As you know, we in Seattle have been acutely touched by COVID-19, especially during those early days of the pandemic. I often tell people that you appear to be the same person in a figurative way that I met high atop the Sheraton Hotel and Towers in 2007, as you were in town for the AIDS vaccine conference. I was wondering, how has your life changed in personal and professional ways since becoming a household name?
Well, there's the good and the bad about that. It's been a most unusual year, somewhat surrealistic in that the enormity of the problem and the acuteness of the problem, which is really in many respects different than HIV/AIDS, which the importance and impact of HIV/AIDS is stretched over decades. And it was something that started off, insidiously. And there were a few of us in the early years of the 80s that got involved. And then as it became clear we were dealing with a global pandemic, it was the gradual appreciation of the globality of the outbreak, a lot of science, a lot of investment, but it was over many, many years. This has been completely explosive, where you have literally 500,000 people in the United States dying in, a year's period of time. And it's completely transformed what I do because I've had to be involved in it from a scientific and from a policy standpoint, that it's been, in many respects, almost a surrealistic year of working literally every day. I have not had a day off in over a year, but it's important, and I hang in there and have the energy to do it because of the enormity of the problem and the acuteness of the problem. A lot of strange things have happened. I've gotten caught in something that's quite different than what we went through with HIV, where we had activists who were confrontative, they were theatrical, they were iconoclastic, but what they were trying to say was very important, and they wanted to gain our attention, my attention. They did gain my attention, and when I listened to them, which is one of the best things I've done, it became clear that what they were saying made absolutely good sense, and that the federal government needed to change the paradigm of how we interacted with the activist community, how we interacted with the entire LGBTQ community, because we were dealing with a very unusual disease that was evolving before our eyes. And the ultimate end game was, despite the early confrontation, the end result was a very positive thing. We embraced the community. The community was value added. They made contributions, and the AIDS effort was far better off as a result of the initial confrontation, which jolted us into a really enduring relationship with the community and the constituents. That's really different from what's going on right now, because what's going on right now is we're trying to address an outbreak in the context of a very severe divisiveness in society, so that the confrontation is confrontation against the principles of public health, where wearing a mask or not wearing a mask, or being in a crowded situation or not being in a crowded situation, has become sort of a political statement of where you are in your ideology, which is really unfortunate because, as you well know, when you are dealing with a disease doesn't know. We used to say this back in the early years of HIV, it's the virus that's the enemy. It's not the people. And in this situation, we try to get people to appreciate that it's the virus that it's the enemy. And the only way we're going to effectively address it is by pulling together in a unified way. And unfortunately, that's not been the case. So how that's affected me is that since I've stood up for the truth, science, evidence-based and data-based approaches towards everything, I have been, on the one hand, praised and idolized by many, and on the other hand, scorned by others who took a more political outlook at what I'm doing and don't like the idea that I'm talking about the public health principles that we need to live by if we really want to get this outbreak under the control. So it's a little bit of a schizophrenic thing, you know. Half of the people love me and half of the people hate me, which is something that I did not have to go through with HIV. With HIV, there was trying to gain attention. And when once attention was gained, it was a very good cooperation, collaboration, and synergy between the activist group and the scientists and the regulators.
I remember Larry Kramer, an early HIV/AIDS activist, said about you originally, before he met you, that you were an idiot, and then later he called you a hero when it comes to efforts to combat HIV/AIDS in the early days of the epidemic. What would you say, though, to that person who's living with HIV/AIDS, who sees this robust response to COVID-19, how quickly these vaccines have been developed, manufactured, and deployed, and wonder why a similar effort wasn't made in those early days of the epidemic?
That is a question, that's a good question, but that it is not infrequently subject to understandable misunderstanding. So, and that is that getting a vaccine against HIV is quite problematic, because the fact is that the body does not make a very adequate immune response against the virus. And one of the principles of developing vaccines in the field of vaccinology is to mimic natural infection, because when you have diseases like smallpox and polio and measles, even though they cause a considerable degree of morbidity and mortality, at the end of the day, the body very, very adequately handles those viruses, eliminates them from the body, and leaves you with enduring immunity against reinfection with the same virus. So when vaccinologists like myself and my colleagues back in 1983, 4, 5, when we started working on a vaccine, we put a lot of effort, but the body did not give us that proof of concept, because the body does not handle HIV very well. So what we have to do, and we've invested literally billions of dollars in research trying to develop a vaccine which does better than what the natural response to the virus is. Whereas with COVID-19, even though it's caused a lot of sickness and death, in the majority of people, the body's immune system handles it extremely well, eliminates it, and most of the people, at least 30, not most, but at least 30 to 40% of the people who get infected with SARS-CoV-2, they don't have any symptoms at all, yet their body's immune system eliminates the virus. So all we had to do with COVID-19 was develop a methodology where you expose the body to the very important spike protein, which is the protein that binds to the cells in the upper and lower respiratory tract, and induce a good immune response. And then all of a sudden, bingo, you got a highly effective vaccine to the point of 94 to 95%. That's the reason why there's a difference, not because of lack of trying. It's in the inherent inability of the body to mount a truly adequate immune response against HIV, as opposed to the ease with which the body mounts a good response most of the time against SARS-CoV-2.
Now, in 1981, you began looking into the virus. 3 years later, you were the director of the National Institute of Allergy and Infectious Diseases. How could we have stopped the spread of the HIV/AIDS virus in those early years, and what kept us from sort of containing it?
The thing that caused the spread, apart from situations where injection drug using, which is a disease get it away from being a crime. It's a disease addiction. But if you look at the modality whereby this virus was spread, not only in the United States, which was predominantly, not exclusively, but predominantly a disease or an infection of gay men, whereas internationally, such as in Southern Africa, it was predominantly a heterosexual disease, that we did not have a vaccine. And early on, we didn't have treatment, despite the fact that we have spectacularly effective treatment now, due to a lot of effort that was put in with resources and scientific commitment. The fact is that the disease is spread by a very natural function, namely sexual activity. And that's one of the really complicating issues of that, is that many people are practicing risk behavior, did not even know they were practicing risk behavior. And then that seeded an outbreak, which then spread really very, very robustly throughout the gay community. And then internationally, particularly in countries such as Southern Africa, where the conditions there, are amenable to that type of a spread. So I'm not so sure what could have been done. Maybe early on, if the Reagan administration had sounded the alarm, whether or not the gay community would have listened to that is still unclear. We'll never know because it never happened. But I guess one of the things that could have been done back then would have been to use the bully pulpit of the presidency to get out there and warn people about the danger of this sexually transmitted disease.
Now, we won't get our own Operation Warp Speed, but what will it take to end HIV/AIDS in the United States?
We put together that plan in 2019 that really got rolling in 2020 to end the epidemic in 10 years in the United States by implementing the tools that we have, by doing things like better and more extensive utilization of PrEP, including the more easily usable injection, long-acting cabotegravir, to get as many people under treatment as possible, to allow treatment as prevention to occur, namely undetectable equals untransmissible. That's an important area. And then finally, to get a moderately effective vaccine. I believe if we do all of those things in a very proactive way over the next 10 years, we can decrease the new infections by 75% in 5 years and by 90+% in 10 years. So I still hold the hope and the anticipation is that by the time we get to 2030, we will have ended HIV as an epidemic, ended as we know it. I don't think we're going to eliminate it, and I don't think we're going to eradicate it, at least not in the very foreseeable future. But I think we can end it as a true threatening epidemic in this country by 2030 if we continue to get people into treatment programs, to get as many people utilizing one form or another of PrEP, and hopefully with a at least moderately successful vaccine.
Julia Braithman at the Boston University, she's in the School of Health, has said that while it's unclear COVID-19 poses additional risks for people living with HIV, it is clear that COVID-19 has disrupted the health system, making it more difficult, more challenging for people living with chronic conditions like HIV. Also, people, having a hard time getting their PrEP. There's disruptions for transgender people and, having to postpone their surgeries and experiencing interruptions in hormone therapies. So what role can the federal government play to ensure that these disruptions are minimized?
That is a good question. I'm not sure the federal government can do much, but perhaps with some subsidizing the state's capability of making sure that the flow of drugs and the availability of testing and a number of the programs of implementation science continue with substantial support. So if you're talking about where the federal government plays a role here, one of the things would be to continue the support for HIV/AIDS for the NIH, for the CDC, and for HRSA, because if you look at the plan, which I described in a paper that I wrote with my colleagues in 2019 in the Journal of the American Medical Association, we described all the things that we need, particularly implementation science. And it involved multiple agencies, not only NIH, but the CDC, the ASPR, the Assistant Secretary for Prevention and Response, HRSA, SAMHSA, a variety of agencies, all of which need to cooperate, collaborate, and synergize in trying to end the epidemic. So that's what I believe the federal government can do, continue support of these agencies that are essentially the implementers of the ending of the HIV/AIDS epidemic.
What role can the federal government play to look at issues like Truvada and how maybe these antivirals can reduce the severity of COVID-19? Or is there no relation between taking these antiretroviral drugs and the control of the virus?
We've been studying what impact COVID-19 could possibly have on HIV besides the interruption of the services that you appropriately and accurately mentioned several minutes ago, is that if HIV infected individuals have some of the underlying comorbidities which make them prone to have a more serious outcome were they to get infected. And I refer specifically to the premature aging, because, the older you are, the more likely it is that you're going to get a severe outcome. And that persons living with HIV have metabolic issues that make it appear, if not in reality, that they are aging a bit more quickly. The chronic renal disease, the fact that HIV infected individuals have more hypertension, heart disease, liver disease, those underlying conditions that when people did analyses of this, they found it wasn't HIV in and of itself, but it was the comorbidities associated with HIV. Now, if you have HIV that's out of control and you're immunosuppressed with a CD4 count of 10 and a viral load of 700,000 to 1 million, obviously you fall under the category of being immune deficient, which is one of the risks of advanced disease. But even a person who's got a CD4 count of 600, 650, 700 is on antiretroviral drug with an undetectable viral load. If that person had been infected for a considerable period of time, particularly if they didn't get onto drugs early on, they could have some of the morbidities that would make it more likely that not that they would get infected, but that they would get a serious outcome.
Should the United States and the states in particular who control the distribution of the COVID-19 vaccines make people living with HIV a priority for the vaccine, or should the vaccine be targeted in communities with a higher level of HIV infection?
It becomes a slippery slope when you designate people by a particular race, a particular ethnicity, or a particular subcategory. I think HIV infected individuals fall within the category of underlying comorbidities. That is for sure. It's definitely recommended. So as soon as the priority opens up for people from 16 to 64, which is where most of the HIV, people living with HIV fall into, that is a priority for vaccination in level 1C. And some jurisdictions are already at 1C, and many will soon be at 1C. So I think that prioritization is coming soon.
As someone who has advised multiple presidents and sort of seen in your own history how the LGBT community felt ignored, what are the public health implications of this overt hostility, the implications of these hostile administrations and these policies towards the LGBT community?
It's very natural, Renee. I mean, when you have hostility towards anyone, it is detrimental to everything about that relationship, including the health of the person. We are right now in a different era. It's become very clear that President Biden and Vice President Kamala Harris feel that there should be equity in every respect to all people, regardless of their age, their sex, their sexual orientation. I mean, in any aspect, there should be equity, and he feels very strongly about that. So I think you're going to see the fruits of that in the coming years.
For Disease Control and Prevention admitted earlier this month in a report that because of longstanding social inequities and higher prevalence of severe underlying health conditions, sexual minority populations might be vulnerable to COVID-19 acquisition and associated severe outcomes, but also admit that because data on sexual orientation are not collected in existing COVID-19 data systems, the effect of COVID-19 on sexual minority populations is unknown. How can we address the concerns of the LGBT community if we don't know the extent of the problem or the areas of concern?
We had a discussion like that with the CDC. They gave some reasons why sexual orientation has not been used, and I think it's almost as if people don't want to put it down. That's one of the real problems. But I think that may be an inadequate answer. So hopefully we can get an answer for you.
What would be your recommendation to someone whose partner is refusing to get the vaccine?
I think you need to just explain to them how the procedure that went into showing its safety and efficacy, thousands and tens of thousands of people in the trial, the decision about safety and efficacy made by an independent and transparent process, and the fact that so many of us confident in the safety and efficacy have gotten vaccinated publicly, including me and including the president and the vice president of the United States. So that's a good reason, I think.
Thank you so much.
All right. Thank you.